Okay, so welcome to the next program. And the topic of discussion today is breaking bad news. I think it's one of the very important topics, whether one likes or not. But I think breaking bad news is something that every physician, every clinician should know how to go about doing it. So, if I may ask you and other members who are in the group, what do you understand by the term breaking bad news? What exactly we mean by bad news?
Madam, if the patient has a untreatable disease or patient may die,
Hmm.
or there is a complication occur during the procedure,
Hmm.
in gynae OBGYN field, maybe there is a fetal death,
Hmm.
or any complication, because every time is an emergency in obstetrics. That's why it's so much in our field.
Absolutely. I think, uh, although for us something very serious turns out to be, bad news. But for example, if we announce to a couple that you will not be able to conceive or you will not be able to have a biological child, so that also may come as a bad news to the couple and the family. So bad news is
Yeah.
something that has serious, consequences and adverse consequences on their life and future, and also it has indirect bearing on the family and society. So this is something that we have seen people reacting with great anger and anguish when they receive it, even if it is not a clinician's fault. For example, if the a couple is not able to conceive, it is not a clinician's fault, but then we see people becoming very upset about the treatment or other aspect of the patient management. uh, what are the common situations you face when it comes to breaking bad news, and what challenges do you see or face or experience when you are delivering bad news?
Yes, madam, regarding infertility, the couples, the male couple may have azoospermia untreatable, and
Mm,
also if there is a blocked tube, or also uterine agenesia, or premature ovarian failure,
mm,
the patients cannot accept that.
mm, mm. So,
Yeah, sir,
the-
Monica, a couple of days ago, we have the same patient that have POF syndrome, and she is not very interested in having child. But whenever we told her that she has such a syndrome and she cannot conceive and having biological child, starting crying, and she has very,
mm,
she became very sensitive, and uh, she was very emotional that time. I
absolutely.
remember there 1 week ago or maybe 2 weeks ago.
Thank you, Dr. Marwa. I think you shared another good example that they're not able to believe it, they are not able to accept it, because everybody believes and thinks that I am perfect and there is no problem with my health. But then when you tell them about their, some condition which interferes with their conceiving or having a biological child, so denial is, I think, one of the commonest reaction that you get to receive. So a lot of time they like to blame somebody for what has happened, because sometimes if they have come to you as a, I mean, if they are seeing you for the like they have already seen somebody and then they're coming to you, and they would like to kind of blame the earlier doctor, whoever treated them, that probably they did not treat me well or they did not identify the problem. So blame game is also very common, and in case if they see any delay in treatment from our side. For example, if we failed to diagnose in the beginning, for example, patient has been coming for regular antenatal checkup, and when they come with the, in the full term for delivery, and you suspect intrauterine death, so obviously they would not like to believe that it could happen. They would like to blame somebody, that probably you did not tell me, timely, you did not treat me properly, or you did not look after me. So even blame is very, very common when it comes to breaking of, bad news. So what challenges do you all face when it comes to breaking bad news? If you would like to share your experience.
Madam, in Afghanistan, patients are they argue a lot. As all the world know about Afghani nature, we are ready to fight, especially in the medical field. They do not accept the complication or any mistake from the health provider. They straightly argue that why you didn't tell me before, or why you did this mistake. That's why if we do a mistake, we hide it because they are argue us.
I
Many,
completely understand. Yeah. Go
uh,
ahead, please. Yeah, please go ahead. You were sharing your experience. Please go ahead. Yeah.
yes, madam. We had many stillbirths in our hospital, and also complications like fetal distress, like CP, cerebral palsy occurred for the fetus, and then we make many excuses for the patients, although it is not true, but we have to do sometimes. But inside we are not satisfied with that we lied the patient, we should tell the truth to the patient, but sometimes we have to do that.
Yeah. Yeah, I completely understand. If you don't have the kind of audience, Dr. Shifazul, like you mentioned about the challenge, the kind of audience that you have, the kind of patients you have, who are not very receptive to the truth or to the situation, and they usually react with aggression and argument. So I completely understand that you would like to, play safe and make sure that you don't get into any trouble by telling them the situation. But at the same time, I'm sure there are situations where you can't hide or you can't tell a lie. For example, if there's an intrauterine death, so whether they blame you or not for the death, but you will have to break that news to them. And then, of course, I know there will be a situation. They might act aggressive. They may start arguing with you. They might behave, in all possible ways. So I think today's session will help all of us. One, to see how can we, you know, uh, handle that situation where the patient party can act aggressive. So as a clinician, as a therapist, as a care provider, can I do something to see how I can, de-escalate the situation and manage the situation in a professional manner. But much before that, I always emphasize, if you build good rapport with your patient and their family member, if you're able to win their trust, and if you're able to help them see as a very responsible professional, there is a possibility then the chances of them blaming you for the outcome can be little less. But I'm not sure, you know it best, what is correct in your country's context. But lot of studies have shown where if you have good rapport, if they have trust in you, if they believe that you are a very responsible and careful clinician, and if you are able to handle their questions and queries, with patience and with respect, so usually they have this impression that my doctor is very responsible, and willfully she or he will not make any mistake and will not do any harm to me. So that's, of course, I'm not covering in this session, that I normally cover in other topics when I help people learn these skills that can help you earn your patient's confidence and have good rapport with your patient and make them feel that you are a responsible professional. But this particular session, we will focus primarily on, if the situation is in front of you and you are responsible for handling it, then let's learn how to go about doing it. I know one session cannot train you for it, but at least it can give you some food for thought. You can try implementing couple of things, on small basis, and then you see the impact of it, and then maybe slowly you can bring about a change in your way of handling the situation. And I'm sure, like you are saying, people react, aggressively. But at the same time, I'm sure some of you must be really be able to handle those situations very effectively, and you enjoy patients' trust, and patients don't blame you for that. Again, I'm not very sure, but I'm just hoping that I'm sure some of you must be really enjoying good rapport with the patient party. But of course, at the same time, I agree, whenever there is something that is unforeseen, it could be death, it could be complication, it could be loss of limb, it could be loss of, something which is very serious in nature. Anybody will act, go into denial. They don't want to accept it. They don't want to take responsibility for it. And I'll give you a number of examples where we as human being also, don't want to take responsibility or want to blame others for what has happened. So a simple example that I normally give, for example, if this glass is lying on the corner of the table and by mistake I hit the glass, so the first thing that's going to come, out of my mouth will be, who kept the glass here? So I will not say that I was careless in, walking around the glass. Why did I not see the glass and why did I not walk carefully? But my first, statement that will come out of my mouth will be, who kept the glass here? So that means I want to put the blame on somebody that because you kept the glass at a wrong place, so I hit it by mistake and the glass is broken now. That's how the human mind functions. So let's go through the slides and understand how can we, handle these situations. How can we handle aggressive patient party? How can we de-escalate the situation? I hope these couple of sessions help you with these skills that you can, use in your day-to-day interaction. And at the same time, my insistence or my, emphasis is on, working on building rapport with the patient beforehand, so that when a situation happens, they don't blame you for being not responsible or being careless or being arrogant. So a lot of time your behavior with them, if it is little rude, aggressive, authoritative, so they already carry a grudge against you. There is a possibility the moment they'll get a chance, for example, when you break bad news, they might react with anger and aggression. So this is just one, deviation from what we are discussing. So let me take you through the presentation and carry the discussion. I hope I am audible and visible to all of you. If somebody could unmute and uh, just say yes, you can. And also if you can see the slides that I'm showing you. I'm just loading the slideshow for all of you. Are these slides visible to all?
Yes, madam.
Thank you. Thank you for confirming. Okay.
Yes, madam.
Thank you. So we discussed about what is bad news, and I think you all agree that anything which is serious and adverse, which is something that you were not anticipating, something that you were not expecting, and it has serious, impact on somebody's life and future, and of course, indirect bearing on the family and society. So that becomes a bad news. Very simple thing, something like that you can't conceive, could be a very serious bad news for a person, for a lady. Maybe her husband will leave her, divorce her, or desert her just because she can't conceive. So it's a very serious news for her. And I mean, in India, a lot of time we see people are, crazy after having a boy as their child, son. That I mean, so if they get to know that it's a girl child, and if it is second or third or fourth girl, so again that becomes a bad news for them, because for them, I mean, if they were hoping to have a son and now they have another daughter, so for a lot of women that becomes a bad news. So I think it differs from context to context also, but mostly it's all about death, complication, some serious, incident. So it is one of the trickiest and most difficult communication, because you have to discuss life, death, poor prognosis, complication, unexpected outcome, and it becomes very difficult to, handle that situation, because it requires a lot of confidence and good vocabulary and control on emotion. And most of the aggressive reactions occur after you break the bad news. Now, what do the patients value? Patients, although they value that the doctor should communicate the bad news in a very clear and empathetic manner, kind of expressing that, yes, I know it's very painful. I know it is very difficult for you to accept. So they don't want us to sound very cold and mechanical when we are giving the news. I'm sorry, you will not be able to conceive. So maybe you have, primary infertility. But for them, if it is not, if there is no expression of compassion or empathy, they feel that we are doing it in a mechanical manner, or we are really not affected by it. And a lot of studies have shown that almost two-thirds of the patients and family, they have reported the bad news encounter to be suboptimal. Sometimes they say the person who was breaking the bad news, the clinician who was talking about it was too blunt, or the place or time was inappropriate, or they got the sense that there was no hope, and that was kind of giving them a feeling that it is end of life for them. So they wanted the doctor to balance, honesty with sensitivity, so that we know that this is the truth, but then can you be little more gentle? Can you be little more humane? Can you be little more understanding? And younger generation doctors actually experience more challenges than the senior ones, because probably senior doctors have learned by doing that you have to be little more compassionate and tolerant, accepting, understanding emotions, and giving them space to express their emotion. Whereas a lot of younger generation doctors, they experience challenge because they sometimes don't understand that why do I have to handle patients' emotion? That's not my responsibility. My job is to break the bad news and tell them the truth, which I'm telling with great honesty. So why should I be expected to calm them down, or act like a parent to them? Actually, breaking of bad news requires advanced level of communication skills and great experience in handling emotions. I think this emotion part becomes sometimes challenging for some of us, and that's where the communication breaks down, because we find it very hard to handle their emotions. Personally, also, probably we are affected by what is happening around us. And lot of time when they blame us for the situation, or when they hold us responsible for the emotions, for the situation, so automatically anyone would feel as though they are put, they are considered as the person who has created the problem for them. So accepting that blame and denying that blame and arguing uh, against that blame becomes very challenging. And that's where it's a very overwhelming situation for any clinician to handle so many situations at the same time. So one really needs to be good at words, then handling emotions and questions that will come from the patient party, and then controlling reaction to the situation. As I said earlier, also, the moment they start blaming us, or the moment they start telling us that you are responsible for this situation, so automatically we go on defense and we also start arguing with them. And we really do not know how to handle that playing game, and not to get into that defense mode. But then one has to really practice it a lot. And I know this part of training is still not part of the medical education. It's assumed that you know it, you will learn it by doing. But I believe this is something that every clinician should learn before they start working with patients, and they should know how to go about handling such situations and de escalating the situation. So, this is what I was telling in the beginning. A word of advice that I want to give to everyone, that please build good rapport with every patient, because you never know which case might turn into an emergency and may have an unanticipated outcome. So, if you have good rapport with your patient and they believe that you are a responsible doctor, you are well behaved, you are nice to them, you are kind to them, you listen to them, so automatically your impression on them will be that you will not do anything willfully or deliberately. And studies have also shown that patients and families are less likely to be aggressive with the doctor with whom they are familiar. So if you really want to, you know, if you really want to, reduce the risk of aggressive reaction, it's helpful to create familiarity with the patient and their family member. So make sure that you keep the patient and the family in the loop by regularly updating them. So whenever they ask for what is the situation, what is the possibility, what are the risks, don't hesitate sharing all that when everything is okay, so that they know what they can expect or what all can happen. They may come up with a lot of concerns. Will everything will be all right? I hope the girl lady will have normal delivery. I hope the baby's growth is fine. That is the time I think we should take out time and be very honest and transparent in explaining them the situation. And at the same time, when you tell them that we anticipate normal delivery, but obstetrics is a very unpredictable branch of medicine. At the time of labor, what happens to the mother's health, or what changes happen at the uterine level, or the how the labor progresses, all that is very difficult to predict now. That we can only say when we actually are in the situation. But definitely we will keep you updated. And it's very important when you take the patient in for labor, keep updating the family. Let the patient's mother or mother-in-law come and see the lady, talk to her, and understand the seriousness of the situation. And when you involve them in decision making right from the beginning, that's where they feel that they were given that space to express their concerns. And you, being their treating doctor, you address those concerns and you involve them in the decision making. Please remember, when the patient is critical, and I know obstetrics is a very unpredictable branch, everything might go very well up to month 9, and suddenly during labor time, something might go, haywire. So the patient and the family, they are actually looming under the greatest fear. So they always fear either the something can go wrong with the child, or the mother might suffer something very serious. So fear of death can actually change anybody's behavior. Even very calm and composed person react very differently when they suddenly feel that there is a possibility of death of the child or of the mother, or any complication. So we have to remember that it is not just the patient whose emotions we have to look into, but it is also the family who is the beneficiary of our care. So it's not that I am examining the mother, I am doing antenatal checkup, everything is fine, so I'm not going to talk to anybody else. But the mother or mother-in-law might come to you, or the husband might come to you with couple of questions. It's important to address their concerns, because that they are also beneficiary of your care. Please remember, when the patient is in serious condition, it is the family who takes the decision on the patient's behalf. And there are a lot of emotions in that instance. So make sure that you address those emotions. I'm not saying give them false hope. I'm not saying give them unnecessary, optimism, but address their emotions, make them understand that you are with them in this tough time and you are trying your best to do what can be done. So I'm sharing a protocol of breaking bad news with you. This is not the ideal one, but then you can customize and design as per your uh, country's context. But this will give you an idea how we can go about breaking bad news in a more structured manner. So, one message that I want to give you: whenever you see there's a serious condition, a patient is critical, or there's a risk to child's life or the mother's life, or there is a possibility of some complication, updating the family and breaking of bad news should always be done by the senior most person. So I've seen a lot of time we ask our residents to go and do it. But as I said earlier, junior doctors or fresh doctors may find it very hard to handle the questions that might come up from the patient side, or the aggression that might come up from their side. So the advice would be that let the senior most person handle the situation. Of course, juniors can be present, but that will be more like a learning opportunity for them. Let them see how you handle emotions, how you handle questions, how do you handle accusation that the patient, that the family might make on you, and that will be a good learning opportunity for them. But then it's very important that the person who is handling the patient through and through should be the one who should be talking to the patient or their family member. So this is a protocol. As I said, I'm going to share the protocol of breaking bad news. So there are 4 P's in the protocol. The first P is preparation, second P is performance, third P is palliate, and fourth P is planning. Let's discuss each P in detail. So when we talk about preparation, you have to prepare yourself before you go and start talking to the patient or the family. And then, of course, we will discuss about the place and also how do you prepare the patient. So let's discuss it, one by one. So when I say preparation of the person who is going to break the bad news, it's very important to first of all know and confirm the facts. I have seen situations where the doctor goes and starts talking about the patient. They don't remember the patient's name, or they don't even know whom they are talking to. Is it the mother or the mother-in-law, or how is that attendant related to the patient? So it's very important to know and confirm the facts, know the patient, know the family members, know the condition, what is the risk, why this condition came up, what is the background, what was the frequency of antenatal checkup, did the patient come for regular follow-up, did patient miss any medicines, any treatment, any warning signs, was the patient informed? So when you know everything, whenever they will ask you a question, you will know what answer will satisfy them. So make sure that you read patient's case sheet, read antenatal notes. I'm just taking this example of a patient in labor, but it could be any other gynecological condition also. So make sure that you read patient's notes, what investigations you have done, how you have reached to this conclusion, what more investigations can be done, or how you are very sure of this diagnosis. So all these things you really need to be up to date, and you should be knowing, so that they don't see you as half prepared. And then when you start talking to them, make sure that you connect with the patient and the family. And that's where it's very important to know whom you are talking to. Make sure that you know the patient's name, make sure that you know the attendant's relationship with the patient and what is their name, because it's important to know, and also showcase that you know the patient well, you know the family very well, and that will help you build connection with the patient and the family. So this exercise usually requires a lot of time, because you never know how the patient and the family might react. Some people might just quietly accept it. For example, they were seen by another doctor, they came to you for second opinion. That means they are already aware of the situation, and they have just here to confirm. And when you kind of tell them, yeah, we have done the test and this is confirmed, this is what is the situation. So probably they may not ask you a lot of questions, or they may not ask you for a lot of time. But most of the times when you are breaking the bad news, they will have a lot of questions to ask you. And for that, you will require time. So never do breaking of bad news in a hurry. I've seen clinicians doing it, before they are going to OT or before they are going to OPD. Not the right way. So be prepared to spend almost like 20 to 30 minutes of time, because there may be an emotional reaction. They may need your time and attention for them to calm down. And in that moment, if you show that you are in hurry or you have another task to do, they don't take it well. It kind of hurts their sentiments that the doctor is not really serious about our condition. In between, taking a phone call or attending to visitor is not a good idea. So make sure that you kind of arrange others to look after the visitor or the phone call, rather than you attending in between and interrupting your discussion with the patient and the family. I'm repeating it once again. Please do not delegate, because we have a tendency to ask our residents and junior doctors to do it. That's not a very good idea, because unless they're fully prepared to handle something like this, they might, get into trouble and create chaos of the situation. The second P about the first P is place. That means setting up for the breaking the bad news. I've seen people breaking the bad news in the OPD chamber with other patients and other staff members around. I've seen people doing it outside labor room, outside OT, outside ICU. It's not a good idea. It's always advisable to sit down at a separate place because there will be emotional reactions. There will be question answers. There will be a moment when they will accuse you of being careless and not being responsible. So when you sit down and do this discussion, one, you're able to provide them that privacy, and even you feel comfortable that you are discussing one-on-one with the patient and the family. In that moment, it's advisable to involve significant others like relatives. So you may see a patient's relative who seems more, composed and more calm and understanding. Make sure that you involve them in the discussions. Or if you have the infrastructure where you have social worker or a psychologist or a senior nurse, it's a good idea because then they can help you handle emotional reaction coming from the patient side. Things like facial tissue, glass of water can be kept handy. That shows your humane side, that you understand that there's a possibility of somebody getting upset and crying. So in those moments when you offer them something like glass of water or facial tissue, it helps them calm down and see your human side. Before you start saying anything, it's important to assess patient's starting point. So it is preparation of the patient. So before you tell anything, you can ask something like this: what do you know about this? So for example, a lady has come, she's in the last trimester of her pregnancy, and she sensed that there is reduced fetal movement, and with that doubt she has come to you, and you, after examining, you realize that it's a case of fetal death. And then when you ask them, how did you sense that there was some change in the fetal movement? When did you notice that? What really warned you? So that will give you an idea that they already have an idea about there's a possibility that it could be fetal distress or fetal death. Sometimes they have been referred by another doctor. So if you just ask them, what has your referring doctor told you? For example, it could be the primary doctor in your system, or it could be the ANM in the area, or the PHN in the area who has examined the patient, and she has kind of realized that there's a reduced fetal movement. So she has referred. So when you ask them, what has your referring doctor told or referring ANM told? So maybe they will tell you that they examined me and they had this feeling that the fetal movement was reduced or less, so that's why they referred me to you. So the idea is, when you start your discussion like this, you are actually first assessing how ready they are, or do they really know the situation, are they really prepared for the situation? Because a lot of time they are not mentally prepared for it, and if they are not prepared, there can be denial, like we said, or there can be reaction. It's also important to check what is patient's information need. Like, for example, what does the patient want to know? A lot of time the lady might say, talk to my husband, please explain to my husband, or please explain to my mother-in-law. Or the patient might say that, please tell me, I want to know first, but don't talk to my husband or my mother-in-law. So it could be, anyway. So it's better to check with the patient, like, uh, whom does the patient really want to me to talk about their condition? And then, of course, please check patient's readiness to receive. Are they prepared? Are they ready for it? And if you see, for example, a lady has come for antenatal checkup, and you see something which is, really worrisome. So, and she's alone. So, would you like to share that information at that point of time when she's all alone? What if she suddenly, becomes anxious, or she starts crying, or she reacts differently? So you will have to check the patient's readiness to receive. And in case if you think that this is not the right moment, you may reschedule it. Not you will not delay it for very long, but you can reschedule so that you have people to handle the situation. And then, as I said earlier also, it's important to ask the patient, whom all do you want to engage in the discussion. Now, for example, if the couple is not able to conceive, maybe they don't want to share it with the other family members and they want to just keep it, secret to both of them. So it's important to ask them, whom all do you want me to share your information right in the beginning. So assessing patients' perception about their condition is very important. A lot of time you will see that they will have illness denial. It's impossible. It can't happen to me. Or they may have wishful thinking. So in India, a lot of time, people will take some kind of prasad from some guru and say that, no, I'm very sure this time I'm going to have a son. So they may have unrealistic expectation or they may have wishful thinking. So we really need to identify these, right in the beginning and at the earliest and address them appropriately. Otherwise, there's the possibility that they might overreact when the actual situation happens. And in case if there is some kind of misinformation, please correct it then and there itself. Otherwise, at the later point, you will have great difficulty coming from them. And of course, if you see that they might overreact, I'm sure this all of you must be practicing. We should not give them the complete bad news in one go. So, for example, if you are suspecting, for example, cancer, so maybe one test has already shown you that there's a possibility of malignancy. But rather than saying that it's malignancy, maybe you would say that it looks like malignancy because the biopsy report or the blood test report says so. But let us do the biopsy and confirm it. So what you're doing, you're building on your initial discussion and letting them know that probably it is malignancy. So when you, tailor the bad news in this manner, they get time to absorb the news and mentally get prepared for what is coming their way. When it comes to actually delivering the bad news, it is very important that you do it in a sensitive manner, but you need to be very straightforward. Because if you try to minimize the severity, of course, the intention would be you want to soften the blow. But trust me, it will lead to vagueness and confusion, and that's where the blame game will start. So, for example, for any condition, if you say, let's see, I think we should be able to manage it, and whereas you know it very well that probably it's not going to bring the result that the patient or the family is expecting, so you are creating vagueness and confusion, and they are likely to blame you for misleading or misguiding or hiding the truth. So it's important to be honest, but the same information can be delivered in a more sensitive manner so that they don't this does not come as a shock to them and they don't get upset about it. When you are doing it, make sure that you use simple language, avoid all technical jargons, avoid all difficult words that you may have difficulty speaking and they may have difficulty understanding. So make sure that you use simple language, a layperson's language, and avoid all technical jargon. You can even draw and explain. For example, use audiovisual aids to explain them whatever you are saying. For example, if you're talking about malignancy or a growth or a change in the size of whatever you're talking about. So if you draw and explain, I think it will have a better explanation to the family and they'll be able to visualize what you are saying. When you're talking to them, make sure that it is not a single monologue kind of a thing. Not that you have to just deliver from A to Z and you have to just quietly listen. Make it a dialogue. Ask questions. Ask them, what do you think about it? Did you know about it? Did you have any idea about it? Did you ever get to feel about it? So give them a chance to speak or even ask questions. So for that, you have to pause frequently and allow them to, speak or even absorb what you are saying. Use silence, and your body language will play a very big role to facilitate the discussion. So when you become silent, it's not that you don't know what to say now, but you're giving them time to absorb. And through silence also, you can express empathy. And your body language plays a very big role. If you have a stern facial expression or rigid body and rigid neck, that again shows that you are not with them in their hours of crisis. So make sure that your body language is appropriate. And we'll be talking about in a minute. And then once you have explained them everything, make sure that you check for understanding. A lot of time we have seen you have told them everything, and in the end, the family might say, I hope everything is fine. I hope the child will be fine. I hope she will recover. That means clearly they have not understood the truth or they are in denial. So it's very important to make sure that they have understood and they are accepting it. So, as I was talking about the body language part, you'll be surprised to know that 55% of the communication happens through your body language, which includes your facial expression and your overall body language. 38% of the communication is through your tone of voice, and only 7% of the communication happens through words. So make sure that your body language, it helps to comfort the patient. For example, when they enter your room, or maybe you enter their room, whatever it could be, if you greet them softly, establish eye contact. See, establishing eye contact is very important because we avoid eye contact when we are either scared or we are doubtful, unsure, or probably we are guilty of something. But when you establish eye contact, that will show that you are confident of what you are going to talk, and also you are compassionate towards them. So make sure that you don't avoid eye contact. Your body posture should be open. Anywhere, if you're sitting with your hands folded, or if you are rocking in the chair, that shows that you are not connected with them. So make sure you're leaning forward and have you're trying to reach them out by maintaining an open posture. Lean forward, that shows that you're trying to reach them. Your tone of voice should exhibit compassion, care, empathy, and understanding. Anywhere, if you're sounding rude, aggressive, intimidating, authoritative, that's going to be counterproductive and that's not appropriate. A lot of time they want to express or they want to ask. You have to give them chance to speak or express, because that's going to actually give them an opportunity to ventilate their feelings. And when they are talking, make sure that you listen to them attentively and pay attention and show respect to what they are saying. So for that, make sure you nod, which shows that yes, I am listening to you, I am understanding what you are saying. Sometimes even accepting emotional reactions without being too reactive is also helpful. You don't have to answer everything. You don't have to clarify everything. You don't have to respond to every emotion. If they are crying, it's okay to allow them to cry rather than saying, what is there to cry? It's not a big problem. Why do you think there are so many treatment opportunities available for this? No, maybe they are upset about what they're going through. It's okay to allow them to express their emotions, and we don't have to react or act on every emotional reaction. But whenever you feel it's appropriate to comfort the patient or the family with appropriate verbal or non-verbal gesture, uh, it would be wonderful to do. For example, if lady is consistently crying and you feel that, I mean, she's really overwhelmed now, and if you put a hand on their hand or hand on their shoulder or on the head, so they feel comforted. They can see your human side. They start calming down and they start getting their composure back. So such small gestures make a huge, impact in showing your human side and also making them calm down. So, how do you go about starting the conversation? I've seen a lot of doctors just keep going and saying, I've seen your report and it has confirmed that it is medical. So, this is more like, this is what is your report. What if you start with something like, I'm afraid I have a bad news to share with you. Unfortunately, I have got some bad news to tell you. Or I feel bad to have to tell you this, but the report reveals something that we did not anticipate. I'm afraid the news is not good. Unfortunately, there is no question about the test result. Or the report is back and it's not as we had hoped. So, what I'm trying to say here, I'm not saying exactly use the same way, but can you be little more softer, little more compassionate in expressing your emotion, or sharing the or starting the conversation. The idea is when you kind of say, "I know we were not expecting something like this, but incidentally, the this report also confirms our earlier, you know, diagnosis. So now I think there is no doubt about the malignancy or metastasis." So your tone of voice, your selection of words, a lot of time when you use the word we were not expecting this. We were really not hoping for this. They feel that you're teaming up with them. That also helps to show that you are with them in their hour of crisis. Now let's understand how does bad news hit patients. See, when you will understand this, you will not judge them for their reaction. Anybody who will be in that state would more or less react in this manner. You will see bad news actually results in cognitive, behavioral, or emotional deficit in the person receiving the news. When I say cognitive deficit, they suddenly feel blank. They don't know what to say, how to behave. Or there can be a behavioral deficit where again their behavior might go out of control, not realizing what is the right way of reacting or responding. Or emotional deficit, that means they lose control on their emotions and they might overreact to the situation. So this is how the human mind handles bad news. So anybody in that state would handle in a similar manner. You can't change the news, but can you give them realistic hopes and make it worse by giving a cold behavior? That's the choice you will have to make. Now, when we say how the patient might react, you will see some of them crying. Somebody might suddenly become silent. Somebody might question you, "Are you sure? Is it my report? Could the report be wrong? Should we not get it tested at another place?" So that means they are taking time to believe or accept. Sometimes they may say, "Please don't tell my husband," or "Don't tell my mother in law, don't tell my family." So, this is how they might suddenly react to the news that we are going to share with them. The psychological response is called DABDA. That means they will start with denial. That's what we say. Normally, the first reaction is denial and shock. How can this happen? For example, to a very hale and hearty man, if you say that, "I'm sorry, you don't have sperms," I'm sure he will not believe it. He will not accept it. He will be shocked. And of course, he will be very upset. So the next reaction will be he will be angry, unhappy, aggressive, even revengeful, may even blame you or the system or the test, whatever. So the idea is denial is usually followed by anger. So there's a possibility that they might react with a lot of anger, aggression, and argument, like you were mentioning that people argue. So that's also one of the psychological response before they accept the reality. The third stage is bargaining. Once they have understood the seriousness of the situation, now they want to bargain to get the best out of the situation. Can we take the patient to another hospital? Can we go for second opinion? Can we try an alternative treatment modality? These are all nothing but different ways of bargaining with the disease, with the situation. But once they realize that this is the truth, for example, if it is fetal death, and you have kind of showed them everything that there is no fetal heart sound, there is no fetal movement, this is confirmed by this test, then the reality seeps in, and that's where they become quiet and they look more like depressed. So depression is not like real clinical depression we are talking about. It's like a stage where they become quiet, sad, upset, but they are more or less speechless. And then finally, the fourth stage is called acceptance, where they kind of accept the reality and they start understanding that this is the fact. So, how do you handle all these stages? Denial can be helped by providing them information. For example, when they say it's impossible, I am hale and hearty, I have been doing so many exercises, I have been eating very healthy diet, I have led a very, very active life. So I can't believe that I don't have sperm. So maybe that's where your test report, when you show them that this is what we got your, semen tested at not one place, but rather two places to be more sure before we share this information with you. We have confirmed from both the, investigations at both the laboratories that actually, there are no sperms, or the sperms are not healthy, or the number is not up to the mark. So denial can only be combated with proper information. When you see them angry, it's important to stay calm, listen to them, and support them rather than reacting or trying to, refute their anger. When they start bargaining, sometimes, yes, something is possible. Do what you can do. For example, if you think you don't have the facility to manage it, but they can always go to a higher center and where they can get probably a help, or at least they'll be happy that they could seek second opinion or the best possible treatment, help them. But a lot of time, the reality is that the fact cannot be changed. So that's where you will have to be more empathetic and help them see the reality and assert and let them see what is the situation right now. When you see them becoming quiet and looking depressed, that's the time you have to kind of give them direction. For example, if it's a case of malignancy or metastasis, and you think you need to refer this patient to cancer hospital, so maybe that's where you will say, see, I understand that you are really very disturbed with the news, but at the same time, now we have to plan how do we go about handling the situation. And it's time that we start considering where do we take the patient for further treatment. So in a way, now you are directing them what needs to be done or how we need to move further. And once you see them accepting the situation, that's where you need to encourage them for accepting the situation and also taking responsibility. So in these moments, empathy plays a very big role. I think this is one virtue we have to very mindfully acquire. And I've seen doctors who practice empathy in their communication, they're really able to win their patient's heart and soul. A lot of time, when you lack empathy, maybe out of fear or out of not having the practice of expressing empathy, you not only come out as a very distant doctor, but even your patients don't feel the warmth that they expect to come from you. So it's not that you are getting emotionally attached with the patient, but it is that you are in fine tune with their affective state, what they are going through. If you can understand and if you can see how I can reduce this patient's suffering, how I can make things better for them, that's the real application of empathy in medicine. So it's a great tool to create solidarity with the patient. There are a number of ways that you can use to express empathy, even verbally. For example, when you say, I can see how upsetting this is. I know anybody would be upset to hear something like this. I know you are not expecting something like this. I'm sorry to have you tell you this, but that's the reality. This will be difficult for anyone. So I understand your reaction is well justified. Even I was also hoping for a better result. So, what you are kind of demonstrating, you are showcasing that I understand that this is a very big shock, and what you are reacting to this situation is very natural, nothing abnormal, and it is understandable. So, in this situation, residents, nurses, and other paramedical staff also play a very big role. Although breaking of bad news is done by the senior host person, but the resident, nurses, and other paramedical staff who are around and with the patient, they need to be more understanding and accommodative to the family's need. For example, there's a lady in the labor room and there is an intrauterine death. Now, the lady is in the labor room, the family is outside. So I'm sure mother and mother-in-law and her husband may want to come in and talk to the lady, maybe to support her or to talk to her or to look after her. At that moment, for example, if we are aggressive with the family and we are just telling, no, 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 you can't come to the labor room, nobody is allowed inside the labor room. What if you say that, see, there are other females, so we can't allow everybody and anybody, but I can allow the mother to go in, to go and talk to the patient. Or maybe once she comes out, maybe the mother-in-law can go and visit the patient. So what you are doing, you are understanding their needs and you are trying to accommodate those needs rather than being strict about the rules of the hospital or the protocol of the hospital. And a lot of time we have seen when the family is, in pain and they are suffering and they're just in shock, at that moment, if our behavior towards them is very, very regular and there is no sign of any being upset or be feeling bad for them, they feel that are we not affected by their pain or their suffering? So I'm not saying that we need to sit and cry with them. But can we be little serious? Can we be little more composed? Can we avoid giggling and talking and laughing in their presence? I've seen cases where there's a dead body in the in the ward or in the ICU, and the staff are laughing and giggling. Or I've also seen, hospital staff shouting at the patient's family or the diseased family, please don't cry here, go outside and cry, there are patients inside. I think these are not the desired responses from professionals like residents, nurses, and support staff. So they also need to be sensitized to the seriousness of the situation. In India, I remember when we were kids, whenever we had any death in the neighborhood, I still remember our mother never used to allow us to switch on the TV or radio. She would say, no, no, no TV, no radio, because there's a death in the neighborhood. That was how people, empathized with grieving family. So I think residents, nurses, and support staff need to be sensitized and need to be taught how to really behave in that situation in a more professional and responsible manner so that you don't kind of make them feel, not affected. Uh, in such a situation, I think the doctor or the clinician who is breaking the bad news, even they go through a roller coaster of emotions. Of course, they are uncomfortable about the patient's expectation. There is a fear of destroying the patient's hope. They feel inadequate in the face of uncontrollable disease, not feeling prepared to manage the patient's anticipated emotional reaction. And sometimes, if you have painted a very optimistic picture, you feel embarrassed to have a different outcome. So, how do you prevent these things? I think it's important to make sure that you give a realistic expectation to the patient and the family. Like sometimes we say it's a normal delivery. It will be a normal delivery. I think again, it's not a good idea. Please do not give. We have seen patients, even with test dose, we have seen patients collapsing. So no treatment, no, investigation or simplest of the simple procedure is risk free. We have seen people having perforated uterus even while doing DNC. So we know no procedure is risk free. Make sure that you prepare them for that. Please accept professional limitation. It's very important, especially in obstetrics. It's very important to make sure that you don't handle cases that you cannot actually handle when the real situation occurs. So we have seen cases where people have admitted high risk cases in a small nursing home setup where you don't have the arrangement for ICU or critical care management. And when you take such risks, and in case if the patient, goes into serious condition or patient requires ICU facility, that's where then you regret your decision. So please accept your professional limitation and don't try to, venture with unnecessary adventurous procedures or responsibility. It's very important to learn your emotional reaction Some of us also have extreme anger issues, aggressive reaction, aggressive behavior, authoritarian behavior, being rude and aggressive and intimidating to patient and family. If that's what you are in habit of doing, chances are in the real situation also you will become equally aggressive and may start having fight with the patient or their family. So keep the family updated time to time, answer their questions, address their concerns, so that you know they you know what is going to come and you are ready to handle it. And if you have prepared the family, if you have informed them about the possible risk or complication, then they would be kind of prepared for it, and that's how you will have lesser tasks to handle. Then documentation plays a very big role. Again, I'm not sure how much of documentation is seriously done in your country, but it's been realized that when you document all communication, whether the patient is not coming regularly for follow-up, not taking the treatment, regularly, is missing the follow-up date, is not taking proper diet, or is anemic and is not taking, supplements. So when you document even those things or whatever communication you have done with the patient or the family time to time, even refusal for something. For example, you said that this I mean we will have to go for LSCS, and the family refuses to go for cesarean section, and they say that no, we want to wait for normal delivery. Even that has to be documented, that the patient or the family was advised cesarean section because of these reasons, but the family is refusing for the same, and we are going ahead with the normal delivery. So that means you have even documented that communication, and that really saves you later. So the thumb rule is communicate what you document and document what you communicate. Okay. So common mistakes that we have seen people making in breaking bad news. For example, they will try to avoid breaking bad news as long as possible. We know it's a difficult communication. Everybody feels scared. I've seen even senior clinicians feeling uncomfortable and not very ready to do the breaking of bad news. So they will try to avoid doing it as long as possible. Some people may not do it at all, hoping that someone else will do it. We have also seen people lying or at best being economical victims. That means they will not tell the complete fact. They may deliberately not pick patient's cues. Patient is upset, patient is anxious, but they will not handle that. They will not address it because they know they can't handle emotions. Then doing the activity in a mechanical manner. A lot of time people think breaking bad news is something that we are just supposed to tell them the fact. That's true. You have to be honest, you have to be transparent, but you are dealing with human beings, so you need to remember that you need to be sensitive while handling that situation. So once you break the bad news, the patient or the family may feel not only hopeless, but they fear that they are going to be abandoned. So it's very important to make them understand that you are not going to leave them in between. You're not going to just, leave them, but rather you will establish a plan with them. For example, if the patient needs to be referred to a higher setup, then you establish a plan, what you're going to do, how you're going to do, whom you're going to refer, so that they know that it is not that you are just sending them without any plan of action. Whatever the current symptoms are, it could be pain, it could be bleeding, it could be swelling, or some nutritional deficiency. So before the patient actually starts with the next treatment plan, treat the current symptoms, and then discuss the next treatment, what options they have, involve them in the decision making, check their comfort, their convenience, and discuss with them how they need to, take the patient further for treatment. And they may want to come back to you for follow up. So establish a time for a follow up. Even when you refer the patient, maybe just for second opinion, even that also, like they'll come back to you for follow up, and it's always right to kind of set up that appointment. Then, wherever you are referring, make sure that if you can arrange for appropriate referral, not only by giving contact details of the person to whom you are referring, but if you could give a call to that person and say that I'm sending you such and such patient, And if you could kindly see this patient and then, brief me about the condition. So you're kind of closing the loop. You're kind of even reassuring the patient that you are not just sending the patient, but you are actually making sure that they get the right treatment, and you are also in the loop. So a lot of time, potential and a practical support system like family, friends, social workers, spiritual counselors, peer support group, therapists, if these people are engaged in the care of patients, I think the emotional part can be looked after by those people. Uh, so maybe in the busyness of your life, you may not be that much available to handle the spiritual and emotional need of the patient, but you can always engage people to provide that support to the patient and to the family. So, to summarize what we have discussed, it's very important to remember that most patient wants to know about their condition, and if done rightly, it actually improves your relationship with your patient. It helps patient and family cope with the situation. It fosters a collaborative relationship between you and the healthcare and the patient, and it can prevent aggressive reaction. Thank you. I'm just stopping to share the screen, and we are open to discussion. So please feel free to share your experience, or if you have any questions, and I'll be more than happy to see how we can discuss that situation.
Madam, we hear different ideas about whether to tell the breaking bad news to the patient or to the attendant. Because if we tell the patient, then the attendant will come. Why you told the patient? And if we tell the attendant, then the patient will tell why you didn't tell me. In between, what to do?
So I think in our countries, in Southeast Asian countries, we have seen that it is the family who is, primarily engaged into patient care. They are the one who arrange for, financial and care, and the day in day out. They are the one who are with the patient. So although the Western guidelines say that to talk to the patient and first check whether you should be sharing the information with the with whom and with family or not. But in reality, I think even in India, we know the family is completely, immersed in the whole communication. But if you can be little mindful of understanding, uh, first of all, checking informally with the patient, that is it okay if I talk about your condition with your mother-in-law or your husband? So in case if she insists that please don't talk about this with my mother-in-law or my husband, I don't know, I mean, I'm just taking an example. And in our country, like even we say it's patient's right, and we are supposed to check with the patient, but informally, of course, we can check with the patient. And if she says no, probably I need to have a dialogue with the patient. I'm talking about one situation one, I'll talk about situation two in a minute. So now I need to talk to the patient, and I say, I completely understand that you don't want this to be discussed with your mother-in-law. But tell me, when she's 24/7 around you, can you really hide this information? Should we really hide this information? In any case, she will get to know. And why not tell it in a manner so that she's also part of the discussion? Now, this is when the patient says, don't discuss with my family. Now, coming to the family saying that don't discuss with the patient. So, I have seen in number of cases in India, an elderly lady having some lady or even gents having some, malignancy. So the family says he's already very senior. I mean, oh, he's very old, or she's already very old. We don't want to tell her that she has cancer. So I remember there was a patient who had, pulmonary cancer. So the family said that don't let the patient know. We don't want to tell her. So rather than saying you are right or wrong, it's important to discuss with them why it is important for the patient to know that I have this condition. See, after all, when we are at that stage, when we have very limited time on earth, we need to understand that the person might have some last wishes to be fulfilled. Maybe you want to say sorry to somebody. Maybe you want to sort out some things. Maybe you want to write your will. Maybe you want to visit a place. Maybe you want to meet with somebody. So I think respecting those last wishes of a person, and in any case, we all know that ultimately all of us are going to go. But why not let them? But again, I'm not saying that you insist that no, the patient should know. But when you have a dialogue like this with the patient's family, they understand your point of view and then they slowly understand, yeah. In any case, when the patient comes for treatment, for example, for cancer, so when they go to a radiation center, can't they see other cancer patients getting radiation? Or when they come for chemotherapy, can't they make out that this is a very, the drug is very painful and this is leading to maybe loss of hair and loss of weight and so many other changes in my body? Anybody can make out that this is something very serious. So you're playing hide and seek with the patient. It's better if the patient knows, and rather we will be able to earn patients' confidence and their cooperation in dealing with the disease and treatment. So that's how you need to have a dialogue with the patient's family. But if they still don't agree, I think it's okay to accept their decision because they have the power to decide. Because in our countries, things are not black and white, they're gray. So we have to, consider from situation to situation what will work best in this situation. But of course, somewhere in the documents, you can make a mention that this is what the patient or the family wants, and keeping their decision in mind or respecting their decision, this is what we are doing. So that tomorrow you're not blamed for not doing your professional responsibility completely. I hope I've answered your question.
Thank you, madam.
Any other question from other participants?
Madam, do we have a code of conduct and color that all the staff of the hospital know that if the patient die, they should know that the color is red, or if there is an emergency, the color is
Yeah.
like
Color coding. Color
purple
coding.
or
Yeah, violet, violence, and if the child is, picked up by somebody, then there are. Yeah. Do you have in your country also or no?
I heard that we have in our country and very big hospitals, but we do not have in our own hospital.
So you can always create that. That's very, good way to announce the code because you don't want to say there's a fire. But what if if everybody knows the code and if you announce that code blue, for example, for critical patient, or code violet for, I think, code red is for, I think, violence. So something like this, I think I can, if you want, I can share that with you if you want me to share it.
Yes, madam, it's very interesting.
I will do that. Yeah, sure.
Thank you so much, madam.
Thank you. So if there are no more questions, should we close it?
From my side, yes, madam.
Thank you so much, everyone. Bye bye. See you next week. Thank you. I will share the recording with all of you once it is ready.